meningocele, myelomeningocele or meningomyelocele, this one, refers to the extension of the CNS tissue through a defect in the vertebral column. So the meningocele is the term applies when there's only meningeal extrusion. Walay uh, CNS tissue involved. Only meninges. And then the spina bifida occulta, considered as the most common neural tube defect, may be asymptomatic bony defect or maybe a severe malformation with a flattened disorganized segment of spinal cord associated with overlying meningeal outpouching. Next, we have trauma. So for trauma, we have skull fractures, parenchymal injuries, traumatic vascular injury, and spinal cord injury. For skull fractures, the resistance to fracture differs greatly in cranial bones since ang thickness sa different parts of the skull kay they vary man. For spinal cord injury, the spinal cord is vulnerable to trauma from its skeletal encasement. So most injuries that damage the cord are associated with transient or permanent displacement of the vertebral column. So sa clinics or sa inyong rotation sa trauma center like sa Soto, so possible maka-encounter mo og cases like skull fractures, parenchymal injuries, and traumatic vascular injury. So under parenchymal injuries, first we have concussion. So what's concussion? Concussion is a clinical syndrome of altered consciousness secondary to head injury, typically brought about by a change in the momentum of the head. So the characteristic clinical picture includes the sudden onset of transient neurologic dysfunction, including loss of consciousness, temporary respiratory arrest, and loss of reflexes. So the pathogenesis of the disruption of neurologic function is unknown, but likely involves dysregulation of the reticular activating system in the brainstem. So share ko lang class. So actually pagbata na ako na I think grade 1 man to. Dili ko kalimot kay ato nga experience na ako. Nagduwa mi sa akong mga classmate niya na nabira man sa akong classmate akong uniform. So akong head directly ni hit sa floor. And then after ato naka-experience ko grabbing a dizziness. Actually na ay sudden brief loss of consciousness pero nakabalik ra pud ko, pero after that ang dizziness grabe kaayo. And then pagdala sa ako sa hospital kay according sa doctor kay nagka-concussion ako. So murag nauyog ra akong ang ulo. So thank God walay other serious injury, just a concussion. So good thing buhi pa man ko ron, so may na lang concussion ra. So other parenchymal injuries, we have contusions, lacerations. So for contusions, it's analogous to the kanang bruise caused by blunt trauma sa skin, di ba? Maka-bruise man ta if natay blunt trauma. So same with sa CNS pod na apoy contusion sa part sa brain. For laceration, it is caused by penetration of an object and tearing of tissue. Also, we have what we call as the coup and contre-coup. So for the coup, uh, a person who suffers a blow to the head may develop a contusion at the point of the contact. That's a coup injury, considered as a coup injury. And then, uh, but after the coup injury, the patient can have the second injury, the contre coup, wherein the brain surface diametrically opposite to it is ma, maka experience og secondary impact that might lead to contre coup na injury. Okay, so if you notice sa concussion, more on ano lang na makita sa brain as shown in the picture. Then, diffuse axonal injury. So, traumatic brain injuries may also damage the deep white matter regions, the cerebral peduncles, superior colliculi, and deep reticular formation in the brainstem. So, microscopic findings may have widespread axonal swelling, indicative of diffuse axonal injury, and focal hemorrhagic lesions. Then we have traumatic vascular injury. Kani siya kay medyo maka-encounter jud mo ani due to uh, if maka-rotate mo or if nana mo sa ER, emergency room, maka-rotate mo sa ER or sa trauma. ER trauma. So these traumatic vascular injury, they are common in cases of what kind of accident? Anybody? Class, are you still there?
Yes, Doc. Sorry, what was the question again, Doc? I interrupt you.
So I'm asking you if regarding sa traumatic vascular injury such as epidural hematoma, subdural hematoma. So this type of vascular, yes, very good. So with increasing cases of MVA or motor vehicular accident, so common na ni siya na mga cases ang epidural hematoma or epidural hematoma, subdural hematoma under traumatic vascular injury. So we'll discuss one by one. Vascular injury in general is a frequent component of CNS trauma. So from the word vascular injury results from the disruption of the vessel wall and leads to hemorrhage in different anatomic sites. So remember, nag-talk ta about katong natay brief uh, review sa histology and part lang sa anatomy po. And we mentioned about meninges. So um, the reason why na ay different types of vascular injuries because of the presence of katong 3 layers na meninges. Let's start with the epidural hematoma. So epidural hematoma shown in the picture. So in epidural hematoma, so the blood, since the dura is this one, kaning this area ang gipoint. Since the dura is supplied by number of arteries, so these arteries most notably the MMA or the middle meningeal artery, they are very vulnerable to traumatic injury. So once these arteries has been torn, so there's extravasation of blood under the arterial pressure that can cause the dura to separate from the periosteum. So ang blood mo accumulate sa kaninga part. So di ba ang dura is tapot man siya sa inner part sa periosteum. So once there's vascular injury, so there's possible accumulation of hematoma here. So this is what you call as epidural hematoma. So in adults, this most often occurs with temporal skull fractures in which the fracture causes the course of the vessel. So a symptomatic epidural hematoma is a neurosurgical emergency. Without prompt diagnosis and drainage, fatal brain herniation may occur within a few hours. After epidural hematoma, we have subdural hematoma. Actually, makita na sa dire ang subdural in this picture, no? So sa subdural, so in subdural, by the way, this is the the gross picture of epidural. So naa siya dire sa ang hematoma, epidural hematoma, then we can still appreciate the dura matter here. While the subdura, in the subdural hematoma, the traumatic displacement of the brain can tear the bridging veins. So remember in epidural, it's the arteries that are injured. In subdural, it's the bridging veins sa brain. I mean sa bridging the bridging veins where they penetrate the dura. So the extravasated blood dissects through the two layer of the dura, producing a subdural hematoma. So grossly, the acute subdural hematoma appear as collection of freshly clotted blood along the brain surface. So the underlying brain is flattened, as shown in the picture, and the subarachnoid space is often clear. So symptomatic subdural hematoma most often manifest within 48 hours of injury, and they are most common over the lateral aspect of the hemisphere. So the treatment is to remove the blood and the associated organizing tissue. Then we proceed to CVD or cerebrovascular diseases. So it can be grouped, this CVD can be grouped into ischemic and hemorrhagic etiologies. So CVD or kanang clinically, we call it as stroke. So this is the stroke is the clinical designation applied to these conditions. Defined as neurologic signs and symptoms that can be explained by a vascular mechanism, have an acute onset, persist beyond 24 hours, and it can be stemmed from two major mechanisms. So ischemia can be ischemia or hypoxia resulting from impairment of blood supply and oxygenation of the CNS, or hemorrhage resulting from rupture of the CNS. So during clinics, so when you consider the patient might be having a stroke, it is very important to as a physician, it is very important for you to tell if this stroke is an ischemic type or a hemorrhagic type, because the management is different. Okay. To give you I'm not an internist, no, so I'm not in the position to give the detailed management when it comes to stroke. But it's very obvious nga sa ischemia, so it is usually caused by uh, embolism or due to blood clot na nag-embolus, while sa hemorrhage, usually, ang common etiology is hypertension or vascular anomalies. So, different ang iyahang management. So, that's why if ang patient sa ER, uh, it is very important na ang patient na undergo dayon og CT scan in order for you to tell if it is ischemic or hemorrhagic type of stroke. Unfortunately, in some provinces, ang CT scan is daily available. Okay ra sa cities like Cebu, possible siya. But how about those patients na sa provinces and layo ilahang ang hospitals available, mga district lang, and most of them, they don't have that kind of facility, the CT scan. So, di sila ka-tell if ischemic or hemorrhagic. So, isa na siya sa reasons nga no, ang patient or mas taas ang mortality when we talk about CVD sa mga patients na sa provinces compared sa cities. So, focal cerebral ischemia or ischemic type of stroke may be due to itong na-mention ako, embolization, thrombosis, or vasculitides. So, it follows reduction or cessation of blood flow to a localized area of the brain due to partial or complete arterial obstruction, again, probably due to embolization or thrombosis or vasculitides. So embolism to the brain can occur from a variety of sources. Can be in cardiac mural thrombi are among the most common culprits, and myocardial infarct, valvular diseases, and atrial fibrillation are important predisposing factors. So brain infarcts are subdivided into two broad groups based on the presence of the secondary hemorrhage. Occlusive brain infarcts generally start as non-hemorrhagic and are called ischemic, while secondary hemorrhage can occur from ischemia of the intravascular occlusive material. So this picture shows the changes in the histology of the brain after hours of brain have suffering from ischemic infarct. So for the first picture labeled A, there's red neurons injury after the first 6 to 12 hours. So, di ba, katong show na ko picture ganina, red neurons. This is the area that shows eosinophilic neuronal necrosis. But this type of red neurons, they are already dead. Then for B, so medyo busy na siya, medyo cellular na siya. So because of the presence of phagocytic cells, such as monocytes and activated microglia. So they are evident 48 to 72 hours. They become the predominant cells, ensuing for 2 to 3 more weeks. And then after several months, the associated response recedes, leaving behind a dense meshwork of glial fibers admixed with new capillaries, and some perivascular connective tissue. So naanay mga lost or tissues that recedes and dili na ma-replace. Di ba, remember ang brain? Brain is once ma-injured na siya, dili na siya capable of regeneration, di ba? So, so that's why ang kanang mga stroke ng mga patients, if ang kanang affected part is very significant na makakause o ka ng mga paralysis, maka-affect sa ilahang motor or even sa ilahang speech. So, mo na yung reason na. Kaya ang brain, dili na siya type of tissue nga mo capable of regeneration. Unlike sa liver maka-regenerate. Pero ang brain, if ma-damage, if significant ang damage due to ischemic infarct, na ipa-anadyoy maka-affect sa motor or sa speech sa patient. So this picture shows an old infarct. Okay, so old cystic infarct showing cavitation from a loss of brain parenchyma. So again, if there's infarct, if there's koan, after months, after days, weeks, eventually there's na part nga loss, mawala sa brain. So 10 days to 3 weeks, most especially if there's irreversible injury. So that part, that affected part liquefies, and then they leave a fluid-filled cavity that continues to expand until all of the dead tissue has been removed. And ang mabilin is a cavitation. Then we have intracranial hemorrhage. So we're done with the epidural and subdural. Then we have this intracranial hemorrhage. This intracranial hemorrhage occur at any site within the cranium, outside the brain or within it, or intraparenchymal. Hemorrhages within the brain parenchyma and in the subarachnoid space, in contrast, are more often a manifestation of underlying CVD disease. So rupture of small intraparenchymal vessel can result in a primary hemorrhage within the brain, often associated with sudden onset of neurologic symptoms, and hypertension is the risk factor most commonly associated with deep brain parenchymal hemorrhages, accounting for more than 50% of the cases. So this hypertensive intraparenchymal hemorrhage may originate in the putamen in 50 to 60 of cases. Other sites can be in thalamus, pons, cerebellar hemisphere, just like shown in the picture. There's a massive ganglionic hemorrhage rupturing into the lateral ventricle. So just to compare brain infarct versus intracerebral hemorrhage. So for brain infarct, the deficits determined by the anatomic distribution of the damage. And in intracerebral, it is clinically devastating. Mostly large part of the brain ang involved. In brain infarct, neurologic symptoms develop rapidly over minutes and continue to evolve over hours. In intracerebral hemorrhage, it could be clinically silent in smaller region. In brain infarct, improvement in severity of symptoms that is associated with reversal of injury. And in cerebral hemorrhage, location of the hemorrhage determines the clinical manifestations. Then we have the subarachnoid hemorrhage and ruptured saccular aneurysm. So the most frequent cause of spontaneous subarachnoid hemorrhage is the rupture of aneurysm, specifically or particularly a saccular or berry type aneurysm in a cerebral artery. So saccular aneurysm is the most common type of intracranial aneurysm, and other aneurysm types include fusiform, mycotic, traumatic, dissecting. So 90% of saccular aneurysms are found near major arterial branch points in the anterior circulation. So this is the what what is this class? The circle of Willis.
Yeah.
So it is shown here the different location of uh, a most common location sa circle of Willis nga possible mo ma-develop ang aneurysm. So 40% is naa sa near the anterior communicating artery. So example, no? So an unruptured saccular aneurysm is a thin-walled outpouching. They are usually an anterior branch point along the circle of Willis or a major vessel just beyond. So if this aneurysm ruptured, it will lead to subarachnoid hemorrhage, and it usually most frequent in the fifth decade, more frequent sa women. Then we have infections. Okay pa mo, class?
Yes, Doc.
Sige, ato ra na i-continue ha. Talalan yung tiwason para mahuma na ni ang CNS. Alright, infections. So infection may damage the nervous system directly through the injury of neurons or glia by the infectious agent, or indirectly by the toxins produced by the microbes. So uh, these toxins have destructive effects of inflammatory response or as a result of immune-mediated mechanism. So four principal routes wherein microbes can enter the nervous system. Hematogenous spread is the most common through sa blood, or direct implantation of microorganism, which is most often traumatic but can be sometimes associated with congenital malformations, just like katong meningomyelocele nga malformation. Then we also have local extension that originate from infected adjacent structures, or the routes of viruses, wherein viruses can be transported along the peripheral nervous system, as occurs in rabies and herpes zoster virus. Under infections, it is common ang meningitis. So acute meningitis or meningitis is an inflammatory process of leptomeninges and CSF within the subarachnoid space caused by an infection. meningoencephalitis, it roughs the brain parified into acute pyogenic. Usually, if acute pyogenic, bacterial ang cause. Aseptic, when we say aseptic, ang cause, viral. And then chronic, for chronic, ang cause, mga TB, or spirochete, or cryptococcal fungal. So those are etiologic agent that could give rise to different types of meningitis. So this picture shows a brain which is partly covered with pus. So under the microscope, we can still see this one portion of the meninges. So this is the brain tissue. This is the meninges, and lots of mga polymorphonicular inflammatory cells which are evident findings in meningitis, in acute meningitis. Neutrophils or polymorphonicular cells, inflammatory cells. Then we also have acute focal suppurative infections. So example is brain abscess. So kani nga part sa brain, brain abscess or focal suppurative infections, they are caused by pyogenic bacteria, sometimes fungi. So this is a localized focus of necrosis of brain tissue with accompanying inflammation and may arise by direct implantation of organisms with this local extension from adjacent foci, just like in mastoiditis or paranasal sinusitis, and hematogenous spread. So grossly, the brain abscess or the abscess, it is a discrete lesions with ang central kay liquefactive, there's a liquefactive type of necrosis. And then ang surrounding unaffected brain is na ay swelling. So that's brain abscess under acute focal suppurative infections. Then we have demyelinating diseases. So these demyelinating diseases of the CNS, they are acquired conditions characterized by preferential damage to the myelin with relative preservation of axons. So the clinical deficits, at least initially, are due to the effect of myelin loss on the transmission of the electrical impulses along axons. So, can remember mo sa function sa myelin? So, this myelin, just a brief na lang. This myelin, they tend to cover ang katong mga processes sa axons. And ang function niya is to for fast transmission of electrical impulses. So that sa brain, paspas ang transmission sa information. Okay. So meaning if there's loss of myelin sa mga processes sa neurons, ang tendency is ang transmission ma-affected, right? So basically ngan gi-simplify ra nako. Under these demyelinating diseases, we have immune-mediated destruction of myelin, which is seen on multiple sclerosis and infections. Speaking of multiple sclerosis, this is an autoimmune demyelinating disorder wherein the autoimmune, by the way class, from the word autoimmune, what do you mean by autoimmune?
own body attacking.
Very good. So it is a type of disorder wherein uh, there's antibodies form in the patient's body wherein ang antibody instead if i-attack niya ang nga mga foreign bodies nga dili part sa body, instead of attacking that iyang i-attack ang own body, iyang i-attack ang kanang own composition sa body. That's why autoimmune. So in this case sa multiple sclerosis, ang autoimmune or ang involved na antibodies, ang iyang i-attack is ang myelin. So that's why there's loss of myelin. So again, the autoimmune is directed against the components of the myelin sheath. So characteristic of MS or multiple sclerosis is this episodes of neurologic deficits that are separated in time and are attributable to patchy white matter lesions that are separated in space. Most common of the demyelinating disorders. So the picture on the sa picture A, so kaning gi-point sa upat ka arrows. So this is a fresh brain that shows the gray-brown plaque. Kaning gi-point niya. This gray-brown plaque around occipital horn of the lateral ventricle is the affected part sa multiple sclerosis. And then sa B, wherein it is stained by a blue, a Luxol-Fast blue periodic acid shift stain in order to appreciate the myelin. So the normal myelin is kanang modern color blue. However, na ay mga part sa kaning part nga nawala ang color blue. So it means there's loss of myelin. So microscopic of MS or multiple sclerosis, there's ongoing myelin breakdown, an active plaque associated with abundant foamy macrophages. Myelin is usually completely absent and axons are relatively preserved. The neurologic symptoms and signs, there's unilateral visual impairment, cranial nerve signs, motor and sensory impairment. Also, we have neurodegenerative diseases. So these neurodegenerative diseases are disorders characterized by the progressive loss of particular groups of neurons which often have shared functions. So the pathologic process that is common across most of the neurodegenerative diseases is the accumulation of protein aggregates. So on this table, listed are the following or the different neurodegenerative diseases together with their clinical pattern, inclusions, and also inclusions. So you just, I will leave this to you to study na lang ang kaninga table. Also, it is important to mention about the prion diseases, still under neurodegenerative. It is a rapidly progressive neurodegenerative disorders caused by aggregation and intercellular spread of the misfolded prion protein, kaning PRP, we also have Alzheimer's disease, still under neurodegenerative. Alzheimer's disease, most common cause of dementia sa older adults, with increasing incidence as a function of age. So progression of AD or Alzheimer's disease is slow but relentless, with a symptomatic course often running more than 10 years. I just want to show the brain, the part of the brain affected by Alzheimer's disease. So grossly, the brain shows variable cortical atrophy. No, na yung mga part nga nag-atrophy. And because of this atrophy, these are marked by gyral narrowing and sulcal widening. So ang mga gyros ay nag-narrow, ang tendency mo dako or mo widen ang sulcus. Okay, and then in Alzheimer's disease, kung ang prions kay katong PRP, ang aggregates po sa Alzheimer's disease are these neuritic plaques and neurofibrillary tangles that are tau-containing bundles of filaments. Parkinson's disease is also a degenerative disease marked by hypokinetic movement disorder that is caused by loss of dopaminergic neurons from the substantia nigra. So I don't know if nakakita na ka ng movie nga about sa katong Parkinson's disease. Ang ganda kay si kalimot ko sa name. Sa to Love and Other Drugs, nakalimot ko sa kuan. Basta about Parkinson's disease to. Hindi to nga movie. Love and Other Drugs ang title. 2010 nga movie. 2010 dugay na 2010. Pero nice siya nga kuan if Love and Other Drugs pero pang ano lang siya. Adult naman mo tanan, medyo na lang siya yung mga part na ano. Pero nice siya nga movie, Love and Other Drugs. Ang kuan kay na ang gadala kay ato siya Parkinson's disease sa katong kuan, iyang character. Which di ko mahimutang si pangalan sa gada.
Si Anne Hathaway, Dok.
Yes, very good. Then si kuan, katong kontra ni Spider-Man ang lalaki. Isa tong kontra ni Spider-Man. Si Jake.
Si Jake Gyllenhaal, Dok.
Gyllenhaal. Yes. Anyway, if ganahan lang mo mutanaw, nindot sad siya. Na-appreciate ninyo ang katong kuan, ang katong symptoms sa Parkinson's. So let's proceed na sa CNS tumors. So this is the last part. Last part sa topic, CNS tumors. So the major classes of primary brain tumors to be considered here are gliomas, glioneuronal tumor, embryonal tumors, and a few less common categories including meningeal tumors. With kaning 2016 WHO classifications that segregates the CNS tumors into 1 or 4 grades. So gliomas, under gliomas. So the gliomas are the most common group of primary brain tumors. Under gliomas, we have astrocytoma, oligodendrogliomas, and ependymomas. So these tumor types, they have characteristic histologic features that form the basis of, the classification. We have primary glioblastoma. We also have secondary. So for let's discuss one by one. So for astrocytoma, we have infiltrating astrocytoma. Under infiltrating, they are classified based on the WHO. The diffuse type, diffuse astrocytoma, it is WHO grade 2. If it's anaplastic or there's the tumor cell shows anaplasia, the grade becomes grade 3. And then the higher grade is glioblastoma. That's glioblastoma, which is WHO grade 1. And then aside from that classification, it is also classified based on the isocitrate dehydrogenase or IDH mutant or wild type. If the astrocytoma is IDH mutant, there's a better prognosis. If it's IDH wild type, usually glioblastoma, it is bad ang prognosis. I guess that's the important part when it comes to classification sa astrocytoma. Okay, sa inyohang level, I don't expect you to appreciate kaning mga very kaning detailed nga description when it comes to microscopic sa diffuse astrocytoma. Enough ra tong kaning classification. Ani na gani word nga anaplastic, usually WHO is grade 3 na. Alright. I don't expect you to kanang ma-master ang kanang even ang kanang ang karaan nga mga patho, they have night times nga they have a difficulty on diagnosing this type of CNS tumor. So sa inyohang level, okay ra nga ma-appreciate ninyo or unsay kabalo mo unsay gibasean sa kaning classifications. Okay. This one guy. If anaplastic, WH grade 3. So usually in anaplastic, it is expected na there's increase atypical mitotic activity consistent. So kana remember na ninyo. Pag abot sa glioblastoma, mo na siya ang katong WHO grade 4. Medyo ano na siya, bati na siya nga type, taas-taas na siya nga grade. The higher the grade, the bad ang prognosis. Aside from those description sa kaning mga astrocytoma, mitotic, include the necrosis and microvascular proliferation. Na gani necrosis and microvascular proliferation, consider glioblastoma. And this one is WHO grade 4. Then we have pilocytic. Pilocytic, from the word there's cytic or like one. So there's a discrete border and there's unique histopathologic molecular characteristic. This is benign. So histologically limited ang brain invasion as shown in the picture. There's biphasic architecture and the tumors are bipolar. There's corkscrew shape and there's also mulberry inclusions. Also oligodendroglioma. This one, ang pinaka features is ang kaning murag egg, murag sunny side up egg na mga tapad-tapad. Because of there's the nuclei of the tumor cells are just small blue round cells, and then surrounded by kaning clear halo of vacuolated cells. So mura jud sila kanang mga sunny side up egg nga gitapad-tapad. Okay. It is oligodendroglioma. It is considered it has best prognosis among the glial tumors. But still, it has anaplastic type. So again, when the tumor is nanagani anaplastic na word, grade 3 dayon na siya. Ependymoma, these are tumors that arise in the proximity of the ependyma line ventricular system. Still, nasa anaplastic na version, WHO grade 3. And same sa other na mitotic, high ang mitotic rates niya. And there are areas with palisading necrosis and microvascular proliferation. We also have embryonal neoplasm, medulloblastoma grade 4. So this one, ang iyahang koan is most common embryonal neoplasm and 20% of pediatric brain tumors. And it occurs predominantly in children compared sa other koan. So ang iyahang location exclusively in cerebellum. So if you're given a case of tumor located in cerebellum, consider medulloblastoma, especially if na other features, characteristics na mo point to medulloblastoma. Again, location exclusively cerebellum, predominantly children because 20% kay pediatric na tumor. We also have meningioma. So kanay meningioma from the word meningo. So it arises from the meninges. So kani. So katong layers that covers the katong 3 layers, so meninges. So they usually arise not sa brain but on the meninges. So meningioma, they are WHO grade 1. They are benign tumors. They are grossly rubbery, rounded, bosselated, and histologically can be daghan siya histologic patterns. Na ay kaning one, this is called psammomatous. These are psammoma bodies. So if predominant ang psammoma bodies sa meningioma, it is classified as psammomatous type of meningioma. For atypical meningiomas, W grade 2, again, basta na yan anaplastic, automatic grade 3. Alright, so ako na lang gipaspas ang CNS tumors kay kato na lang mga features na obvious na dapat ninyo timan-an. Na mga pictures, ubang pictures dili man maklaro. Di man mo ka-identify yun sa mga kuan. So kato na lang akong gipang point out i-remember, okay? And reading assignment, genetic metabolic diseases. Toxic and kuan. So that's it. Do you have questions?
None so far po.
Wait, before tamo kuan kay nakalimot kog butang og Bible verse. Wait give me some few seconds lang. Sige kani. Are you still there? Last na guys. Please,
Yes,
please
Doc.
allow me to share lang this Bible verse. So in John 14 verse 6, in John chapter 14 verse 6, so Jesus declares, I am the way, the truth, and the life. So no one can come to the Father except through me. So guys, I don't know if for the past few days or week katong gubot sa ato ang nation due to kanang gi-capture ato ang former president, gidala sa other country para dito ikuan sa ICC. So grabe grabe ka divided ang nation. I don't know if affected mo or busy mo sa inyong med studies. But anyway, sa social media, isa ka sa mo maabot, ma-hear ninyo ang kanang issue about sa kanang basta kanang issue naka-divide jud siya sa atong mga Filipino. Regardless kung sa status sa life. So that's why I just share this Bible verse. Atong gi-declare that Jesus declares that I am the way, the truth, and the life. So walay laing nakibaw kung unsay tinuod, no, unsay kamatuoran or sa Bisaya pa. Sa panahon karon kay dali ra kaayo matago ang kanang kamatuoran. Daghan na kaayo fake news nga mas spread. So what should we do para makibaw ta? So we focus our eyes to Jesus. We focus our eyes to God. So when we focus our eyes, when we pray and we ask for the guidance nagikan sa iya, siya ang mag-lead or mag-guide ka nato or maghatag ka nato sa kung unsay kamatuoran. Whatever happens sa atong surrounding, whatever happens sa mga kuan, dili na lang ta mo join kanang kuan because it will just cause division. But we focus our eyes and focus to Jesus. Because again, Jesus is the only way, the truth, and the life. So I guess kana lang. Again, please ko read sa kani nga topic, central nervous system, medyo taas-taas siya. I tried to discuss it in one lecture. Medyo jud siya. Pero if you give time to read ang kaning part sa Robbins kay slowly ma-appreciate ra pud ninyo ang kaning topic. So if you don't have any questions,
Doc, is it okay for
okay.
if the class can ask for our lecture today?
You mean pa-send mo? Sure, mag-send
Apo.
ko.
Thank you, Doc.
Ako lang siya i-send og kanang kuan kanang gi-divide ra kay murag dako-dako siya og kanang kuan. Di siya ma-send in one di ko kamahon sa pag-send in one.
Apo, Doc, copy po. Thank you.
Anyway, i-send lang jud ni nako ni. All right? Again, thank you so much sa inyong time and sa pag-understand. And God bless you.
Thank you, Doc.
Thank you, Doc.
Thank you. Pag-dinner na mo.
Ikaw po, Doc.